program for the postgraduates in pathology. Today, we have a slide seminar from gastrointestinal tract lesions presented by Dr. Kedar Dhiodar, Professor of Pathology from Tata Memorial Hospital, Mumbai, and Dr. Pooja Sapuja, Director Professor, Head Department of Pathology from the GB Pant Institute. Chairing today's session is Dr. Anita Borges, Consultant Pathologist, Center for Oncopathology, Tata Trust, Mumbai. We have 4 residents today with us: Dr. Manish Kumar Pradhan, PGY3 from IMS BHU, Dr. Sherin Jacob, PGY3 from Safdarjung Hospital, New Delhi, Dr. Arushi Agarwal, third-year resident from SNMC Agra, and Dr. Garima Gupta, third-year resident from AIIMS Patna. They'll be interacting with Dr. Kedar and Dr. Pooja with all the cases, and we'll be taking questions and clarifications from the attendees to Dr. Kedar and Dr. Pooja as the seminar progresses. I am Dr. Ramaswamy, and along with me, Dr. Bonita. We are moderators for today's session. Our webinar hosts are Dr. Anita Borges and Professor Sumit Gujral. These are some of the reminders for the attendees. A couple of disclaimers. Before proceeding to the seminar, a quick reminder of the upcoming talks. We have a lecture on 23rd August on cell counter flags and slide review criteria by Dr. Anil Handu. And on next Thursday, we have a slide seminar on approach to pancytopenia with an emphasis on the non-neoplastic process. So with this, I hand over the stage to Dr. Pooja. Pooja ma'am will start the discussion with her cases. Ma'am, over to you.
Good evening to everyone, and I'll now share my screen so that we can start the seminar. Okay, so hopefully you can see the screen. Arushi, can you see the screen?
Yes, ma'am.
Okay, so let's start.
Make it full screen, ma'am, please.
Yeah. It's not full screen now?
Yes, ma'am. Yes, it's.
Okay. So, Arushi, we'll start with you. Case number 1 was a 49-year-old female patient with completion proctocolectomy specimen. What does completion proctocolectomy mean?
Ma'am, procto means rectum and colon means colonectomy means colon. That is removal of whole colon, including rectum.
Yeah, but what does completion mean? Now, when the surgeon writes completion, he usually means that some surgery has happened in the past. And therefore, now this is a completion of the previous surgery. So when you get such a thing written on the form, it is a good idea to check with the surgeon what surgery was done earlier and what was the histology report on that case. Okay, whether it was done in your own center or some other center, either way. So now the patient had a previous surgery, okay? And now the surgery, the slides that we have shared with you are showing, I'm just showing you the 3 slides, which are just different areas and magnifications of the same histological finding, okay? One was this, and then this, right? These were the 3 slides I had shared with you on the seminar. Yes. So, Garima, would you like to tell me what you've seen on this?
Yes, ma'am. This section shows a mucosal biopsy showing elevated and depressed border at a small bit of muscularis mucosis identified at 12 o'clock position, and mucosa lamina propria is bit expanded due to as when compared to muscularis mucosae with a back-to-back arrangement of gland, and at this power only we can identify some of the crypts are atypical.
Okay, so the only thing is this is not, I told you this is a completion proctocolectomy specimen, so this is not a mucosal biopsy. This particular section is showing you an area mainly from the mucosa. Okay, and as you have rightly pointed out, now in the lamina propria there isn't anything very much happening, which we can come back to in high power later. But as you have pointed out, there are some glands which are showing some atypia. Would you like to describe these glands?
Yes, ma'am. There are few atypical crypts which are admixed with the normal crypts. In these crypts, we can see the features of mild dysplasia in the form of nuclear stratification, nuclear enlargement, nuclear overcrowding. Some of the nuclei are trying to reach the luminal side also. So it is in my opinion, it favors in the point of low grade dysplasia, ma'am.
Okay. And when would we call it high grade dysplasia?
When the loss of polarity is there, ma'am, first of all. Then loss of architecture is there. Nuclear size is almost or more enlarged, and prominent nucleoli is there. So we will say it as high grade dysplasia, ma'am.
Okay. Also, when the nuclei are reaching the luminal surface.
Yes, ma'am.
Okay, then also it goes in favor of a high grade dysplasia. Okay. So now you've seen that there are these few areas which are showing a small number. See, only how many crypts are atypical in this field?
4 crypts, ma'am.
Yeah, 4 crypts, right? One over here, maybe this one also, can't say for sure, but this one and then these 3 here, right? In this one also, there is a cluster of few small crypts which are, sorry, we'll not do this annotation because as last time, if you remember, the annotation did not work over here, okay? So we'll not do annotation because it somehow removes the full screen. So can you see the arrow?
Yes, ma'am.
Yeah, so here also there is a cluster of atypical crypts, correct?
Yes, ma'am.
Now, what do you think is the your findings you've described, Garima? What do you think is the diagnosis in this case, in your opinion, so far as what you have seen?
Ma'am, it might be dysplasia due to we did proctocolectomy because of some reason like IBD. It might be patient might be having some etiology for which we did the IBD, for which the patient might have developed this kind of dysplasia.
Okay, that's one thing, very correct. But when you see this dysplasia, just in a few crypts, very few crypts at a time, okay, and they are not starting at the surface. You see the surface is the lower down here
Yes,
in the lower right corner, right?
yes, ma'am.
So here also you can see the surface is here in the right side, right? So dysplasia normally typically starts at the surface. So these are not classical dysplastic foci of, say, IBD, right? But we are having some cluster of crypts which are showing this dysplasia. So what do you think this is then? Any other term we can give it?
It might be due to repair or
No. You are very right. It is dysplasia. Okay. It is not due to repair. It is dysplasia. But when you see just a few crypts showing this dysplastic change, then we give it a different name. Now, I'm just sharing with you a few more slides of the same case. So here you can see a few more crypts that are dysplastic. Here again, correct? The same finding. Am I right?
yes, ma'am.
Few more crypts that are dysplastic. But what are you seeing here now? Do you want to describe this? This is from the previous surgery.
Here there is, ma'am, back-to-back arrangement of gland, might be some adenoma kind of thing, tubular adenoma.
Okay, I'll take it to a higher part. Besides back-to-back arrangement of glands, anything else that
Yes, ma'am. There is cryptapsis and cryptitis. There is cryptapsis, ma'am. I can appreciate
correct. Anything else?
anything.
So what is the, can you see goblet cells in these crypts?
No.
The crypts on the left side. Can you see any goblet cells here?
No, ma'am.
Yes, no. It's just a yes, no question.
No,
No,
ma'am.
right? So, and here this is the relatively normal part where you can see abundant goblet cells, which is the normal type of mucosa of the large intestine. Correct?
Yes. Yes, ma'am.
So you are seeing there is loss of goblet cells, eosinophilic cytoplasm, and again that slight dysplastic change and some back-to-back arrangement of glands over here, and here also some dysplastic change, right? So the
Yes.
previous colectomy specimen did show these changes, okay, of adenomatous change. Okay, this is another high power of the same. So this is called aberrant crypt foci. Okay, that means
Okay.
there are aberrant small clusters of crypts. It can be a single crypt or multiple crypts that have this dysplastic change. It is not a proper adenoma. Okay, but
Okay.
do you know any synonyms for aberrant crypt foci? So you said adenoma. Now, these are very tiny. So what may be another name for it then? Microadenoma.
Microadenoma.
Okay. So these are also called microadenomas. The significance of this, you already told us one thing, that maybe in IBD there is some dysplasia occurring. Any other condition in which you know that you can get these sort of aberrant crypt foci? I showed you that the patient in the previous turn had a adenomatous change in the previous colectomy specimen, right?
Yes, ma'am.
So anything else that you can think of that in conditions in which it may occur? Anyone else? Manish?
It might be a precursor lesion for future adenocarcinoma.
Precursor for?
Uh, it may predict tubular adenoma may occur in future or carcinoma transformation.
Okay.
Uh,
So this can be seen as an early biomarker of carcinoma colon, whether it is related to IBD or whether it is related to multiple adenomatous polyps or whether it's related to just a colon cancer. And therefore, where are they likely to be found vis-a-vis the vis-a-vis the tumor? Garima, any idea where they'll be found?
Sorry, ma'am.
So they
Ma'am,
are usually seen in the normal colonic mucosa 10 to 15 centimeters from the tumor. Okay? Or they can be irregularly scattered if it is a case of familial adenomatous polyposis. And how can they be detected endoscopically? Especially important in cases of IBD. You may want to detect such foci endoscopically in IBD. So in IBD, how can they be detected by the clinician?
Ma'am, narrow band
Any
imaging.
special method they use?
Narrow band
Stain.
imaging.
Very good. Narrowband imaging. Anything else?
Maybe special stain can be used.
methylene blue, ma'am.
Sorry?
Special
Huh?
methylene.
Yes,
Methylene
very
blue.
good. Methylene blue. So methylene blue, chromoendoscopy or narrowband imaging. Very good. Okay. So they usually come as single or multiple crypts. They can be flat or elevated. They can be goblet cell rich or poor. And they can stain positively for cancer stem cell markers or for P53 and beta catenin also. So that is evidence that these are neoplastic in nature, correct? Now some more sections from the previous resection showing that this is in the previous resection we saw a moderately differentiated adenocarcinoma. Okay, you can see the desmoplastic reaction, the areas of necrosis, okay? And then this typical adenomatous polyp, correct? So like I told you, now the reason I've shown this slide is, can you tell me where this adenomatous change is beginning?
So
In the surface or the base?
Normal. There is abrupt
Surface.
transformation.
Right?
There is
So
normal
which begins
epithelium,
in the
and there is
surface. And therefore, the typical adenomatous change will begin in the surface, which differentiates it from reactive atypia also. And aberrant crypt foci are usually not so many in number. Okay. Now, in that previous resection also, we saw some aberrant crypt foci like this. Again, see, this is in the base near the muscularis mucosae. This is the gross specimen of the tumor. Sorry. And now, one thing that you have to remember in this case is, can you see any polyps in this tumor?
Yes, ma'am. One polyp.
I'm sorry, I cannot ask you to annotate, but yes, here you are
Yes.
seeing some two
Yes.
polyps.
Hmm.
But would you call it familial adenomatous polyposis?
No, ma'am. More than 50 polyps are required for calling it. More than 100 polyps. 100 polyps for calling it as familial adenomatous polyposis.
Correct. You need more than 100 polyps, right?
Yes,
So
ma'am.
now, but the only other thing to remember is that sometimes, now you can't see any polyps, but if you look in high power, can you see anything here? Which I am pointing with the arrow.
Some elevations are there, ma'am. Some elevations.
Tiny nodular elevations, which
Yes,
could be adenomas or these microadenomas. Okay, so
Okay.
these tiny nodular elevations are not to be missed grossly, they must be sampled. Okay, so okay, so now you've already told me when is it FAP, right? And what are the other types of adenomatous polyposis that you can that you know of?
Lynch syndrome, ma'am. It can be associated with Lynch syndrome.
Yeah, and Lynch syndrome has association with what other tumors besides colonic?
thyroid, endometrial, breast
Huh?
cancers.
Yeah, yeah.
Endometrial, breast cancers.
Correct. Endometrial and breast are especially important, but there are many other cancers that can be associated with Lynch syndrome. Now, the mutation in adenomatous FAP is the APC gene germline mutation. Now, what are the types of adenomatous polyps? I asked you. You told me Lynch syndrome, FAP. Then there is a MUTH or MAP. It's called MUTH associated polyposis. Now, I haven't written the full form, but can you tell me what is this AFAP? Anyone? Now, what if these polyps are 50, like she said, or just 20? Huh? What if the polyps are few in number? Then?
Atypical.
reduced.
No. Okay, so the clue is in the A, but it's not atypical. Anyone else?
Attenuated, ma'am.
Attenuated.
Attenuated
Correct.
familial
Attenuated. Right? So it is attenuated familial adenomatous polyposis when it is less than 100. Sorry. So let's go to case number 2, which is a 56-year-old female patient. I think, Arushi, you can take this case. Okay. 56-year-old female patient with pain abdomen, endoscopic biopsy from tiny 5 millimeter gastric nodule. This is the slides I had shared with you. Can you tell me first what you're seeing just in this slide?
Ma'am, microphotograph shows irregularly, haphazardly arranged gastric foveolar glands, and some are cystically dilated. On another bit, it can show haphazardly arranged smooth muscle bundle with and scattered chronic inflammatory infiltrate.
Yes. Anything else you're seeing here? Anything here in this area?
Mucosal prolapse, ma'am, you can say.
No.
Ma'am, these are capillaries. Capillaries filled with
Listed capillaries here, but here in the crypts, foveolae, are these totally normal?
no, ma'am, these are dilated.
Okay. Anything else?
Dysplastic, ma'am, somewhat.
Not dysplastic, nuclear, nice and basal. Okay, let's go to the next. This is a high part. Now in the high part, tell me what are you seeing here?
Ma'am, here we can see mucosal prolapse. Ma'am, mucosa is extended
Why are you
downwards.
calling it mucosal prolapse? Mucosal prolapse is not very commonly used for the upper GI tract in the stomach. And crypts, normally, where do the crypts go? The foveolae, they do dip down into the mucosa. The normal stomach, what do you have? You have the foveolae, and then below that, what do you have? The gastric pits,
It's,
which are composed of what?
ma'am, gastric pits, ma'am, having mucin cap.
Having, sorry,
Mucin cap, ma'am.
anything else they have? How do you differentiate between the cardiac and the fundus and the antrum?
Ma'am, in fundus, there are a lot of parietal and parietal cells and oxantic cells. In cardiac, we have mucosal glands more.
Yeah, you have mucin glands.
Ji,
The mucin glands, right?
yes,
So
ma'am.
here, is there anything else you are seeing in this area? Can you tell me, are these all the normal foveolae? What are these cells looking where the arrow is pointing?
Ma'am, goblet cells, these are the goblet cells.
So goblet cells, if they are present, then what does it mean?
Ma'am, intestinal metaplasia.
Yeah. And anything else you're seeing that looks atypical in this slide? So describe this particular slide to me again. One is that you've seen a few dilated foveolae with intestinal metaplasia. Anything else?
Ma'am, dilated capillaries filled with
Okay.
fibrin thrombi. Ma'am, surface epithelium is denuded.
Why is it denuded? ये है तो सही पूरा surface epithelium यहाँ सब जगह है. Why is it denuded? Not denuded at all. Then what is happening here in this region?
Ma'am, chronic inflammatory infiltrate.
Yeah, and where are the normal gastric crypts or pits or specialized glands? Where are they?
Ma'am, these are absent. Ma'am, atrophic.
Atrophic, right? So they are absent, and therefore this is what can we call this?
Atrophic gastritis, ma'am.
Yes. And now what's happening in this piece?
Ma'am, in this, ma'am, stroma is filled with small.
Not
In
stroma, the lamina propria and maybe the muscularis. You can see some of the muscle here.
yes, ma'am. It is infiltrated by small clusters of atypical cells.
So anything that you think, any possibilities here for this? What do you
Ma'am, might be neuroendocrine.
Okay. So here you told me your findings. What is your complete diagnosis in these 3-4 tissue pieces, which are all on the same slide?
Ma'am, chronic gastritis with intestinal metaplasia and ma'am with neuroendocrine cell hyperplasia.
Only hyperplasia?
Ma'am, neuroendocrine cell neoplasm. Ma'am,
Neoplasm.
yes.
Okay. And what about atrophic gastritis? You should include that also. Chronic atrophic gastritis with intestinal metaplasia and a possible neuroendocrine tumor. Now, did you see any neuroendocrine hyperplasia in any of these slides? What are these?
Yes, ma'am. Nest of neuroendocrine cells.
Yes, these are
Nest.
small clusters of neuroendocrine cells. So this could be a focus of neuroendocrine hyperplasia, which just points to the etiology, of course, over here. and how this condition has evolved, right?
Yes. Yes.
So what further tests would you like to do to confirm?
Ma'am, we can do IHC, synaptophysin, chromogranin A, CD56, which is also called NCAM.
And anything else to give the final impression? You said neuroendocrine neoplasm. Now, if I want
Yes.
to say neuroendocrine tumor or carcinoma or what?
Ma'am, we can also do mitotic rate and Ki67 labeling index.
Correct. Okay. So these are the two things that we will do. Besides counting the mitotic activity, we'll also do a MIB1 stain, and we will do a synapto and chromogranin stain to confirm that this is a neuroendocrine neoplasm. So this is another high power of the same, and you can see here the neuroendocrine cell hyperplasia, right?
Yes.
And then this is a synaptophysin stain. Now, would you like to tell me what you're seeing in the two different pieces in the synaptophysin stain?
Ma'am, here there is diffuse positivity, and here some small nest shows positivity.
Yes. So, what do you think is happening here? What if you had just this piece, the one on the right? What would you call it? If you have this piece on the left, synaptoposit, you'll call it a neuroendocrine tumor, right? You'll wait for the MIB1 or mitotic index to say whether it is, give the grade or call it a carcinoma, is usually on histology first. This did not look like a carcinoma. It looked like a tumor, right? Well differentiated. So now what will you call this piece if you got only this alone, the one on the right? You said it earlier.
Ma'am, only foci of neuroendocrine hyperplasia.
Yes. So what are the types of neuroendocrine hyperplasia that occur? Some patterns that we know of?
Ma'am, nested pattern.
That's neuroendocrine tumor. But in hyperplasia?
Ma'am, glandular pattern,
Huh? And?
trabecular pattern,
Sorry?
trabecular, ma'am.
You have a linear pattern, you have a glandular pattern, you have a nodular pattern, and usually it begins with this linear pattern, okay, and then later glandular solid clusters of the cells start developing, and only they achieve a certain size that we call it a neuroendocrine tumor. What size is that?
Sorry, ma'am.
What size does this reach when we call it a neuroendocrine tumor and no longer call it enterochromaffin or neuroendocrine cell hyperplasia? Anyone else? Manish? Sharon?
More than 1 centimeter.
2
No,
centimeter, ma'am.
usually half a
2
centimeter.
centimeter,
Okay?
ma'am.
No. It's usually half a centimeter, or if they are endoscopically visible, then also you can call it a tumor rather than a hyperplasia. Okay? So this is the high power of the same. You can see the linear pattern and you can see the solid nested pattern as well. Okay, this is the linear pattern. And this is of course the tumor. And this is just another case to show you how it can sometimes be very subtle. Okay, again here you can see there is inflammation in the lamina propria lymphoid aggregates, and here you can see these small solid clusters of what appear to be neuroendocrine cells, right?
Yes, ma'am.
In this. Here, I've only circled a few, but where the arrow is showing, there are quite a few of these actually, right?
Yes, ma'am.
So now when you do a synaptophysin in this is how we saw that pattern in this case. Okay. And this is of course synaptophysin of the antral mucosa. This is more common in the body. But in the antral mucosa, you have to be careful not to, confuse it, because here the neuroendocrine cells are present in this band-like manner. Okay, that is normal. That they are scattered throughout the crypt, but in a band-like manner at the base of the mucosa. And this is in the antrum. And here, of course, this you are seeing in the body mucosa or fundic mucosa. So, what is the 2017 or the WHO recent WHO grading system for neuroendocrine tumors?
Ma'am, it divides neuroendocrine tumors into neuroendocrine tumors. Ma'am, neuroendocrine neoplasm into neuroendocrine tumors and neuroendocrine carcinoma. Neuroendocrine tumor further divided into grade G1, G2, G3 on the basis of mitotic rate and Ki67 labeling index. Ma'am, neuroendocrine tumors are well differentiated tumors, while poorly differentiated tumors, neoplasm, gives some different category known as neuroendocrine carcinomas, which include large cell neuroendocrine carcinoma and small cell neuroendocrine carcinomas. And ma'am,
Correct.
another category, menin, mixed neuroendocrine and non-neuroendocrine tumors, neoplasm.
Yeah. So one is this difference, and how else is the 2017 system different from the 2010 system?
Ma'am, poorly differentiated in previously
Sorry, continue.
poorly differentiated kept in G3 category. And ma'am, as we see according to
Poorly
genetic,
differentiated is not given a grade at all because it's already poorly differentiated. Okay.
okay,
What
ma'am.
about the mitotic activity and the Ki67 index?
Ma'am, Ki67 now the cutoff is 3%.
Yes.
Ma'am, previously it was 2%.
Correct. Good. So here we have the recent system in which the cutoff you can see is 3%, 3 to 20 is for grade 2 and more than 20, which remains the same. Okay. And also, so therefore now grade 3, which we earlier used to talk of, is now divided into either net grade 3 or just neuroendocrine carcinoma, which is not given a grade, it's just called a carcinoma, right? So you don't have to give it a grade. Okay. Then now, how do you report the mitotic activity or the Ki67 index?
Ma'am, in the area of maximum staining called
Yes,
hotspot,
correct. Very good.
staining at staining microscope magnification, ma'am, 500 cells are counted.
And then,
And then, ma'am, we take out the percentage.
so do you find it easy to count those 500 cells on your microscope?
No, ma'am.
Then, what do you do? What is eyeballing? And what is the recommended way to do it? Is it just counting it on the microscope, which is called eyeballing, or some other method? Sharon? Manish? Manish, why are you not visible at all? Nor can I hear you.
It is sound. And
Manish, can you tell me what is eyeballing and what is the recommended method for counting Ki67?
ma'am,
Sorry? Okay, who wants to tell me? Arushi Garima? So eyeballing is when you just look at it on the microscope and you give your approximate estimate actually. So that is called eyeballing. So you think you may do it very diligently, but still at the end of the day, you're not really being able to count each and every cell, right? And then take out, how many are positive and negative. So that is eyeballing. What is recommended now is that you don't do eyeballing, at least not for those which are on the borderline of a grade. So if it is clearly grade 1, very few mitotic figures, very few Ki67 positive nuclei, my eyeballing will still do. Or if it is so high that it is definitely more than 20%, 50, 80, 90%, then again, it's fine. Eyeballing is fine. But if it is in the grades where you need to count to see whether it's grade 1 or 2 or grade 2 or 3, then you should ideally print the thing or take a photograph on the screen and actually count the number of positive nuclei vis-a-vis the total nuclei, maybe by using one of those, hematology cell counters, which we use for differential counting in EMAT, and you take out the percentage from that. Okay, that's the way that you should actually be doing it. So, so you assess the hotspot, you round up, you count all this Garima and all told very nicely, and and if mitotic activity and Ki67 are discordant, you use whichever is higher, because that is more likely to affect the prognosis of the patient, not the lower one. So you use the higher one, and you do photographing and printing, or just photographing. You do not do eyeballing. Okay. Now, this is a bit controversial. Which nuclei should we count as positive? Any nucleus that is staining, only the ones that are showing a grade 2, grade 3 staining, what should be counted? Okay. Now, this is just from one of the, this is debatable, but this is from one of the recently published articles, wherein that author prefers to use any discernible staining of Ki67. And a lot of people do that any staining, even if it's a faint staining, it should be counted. Okay? But this is something that has been debated, and different people do have a little bit of different opinion in the same. Now, again, just to remind you that Ki67 threshold is not for differentiating NET grade 3 from NEC. So, Manish, how do we differentiate them? Manish?
Yes, ma'am.
How will we differentiate? We are not going to use Ki67 or mitosis to differentiate NET grade 3 from NEC, neuroendocrine tumor grade 3 from neuroendocrine carcinoma. So, how should we differentiate?
Based on invasion,
Sorry? Just speak into the mic. What did you say?
based on invasion.
No, not on invasion. Neuroendocrine tumors have also been known to metastasize. So it is not on the basis of invasion. What is the system of classification? NET, what do we call them? Well differentiated, moderate, or poorly? What do we call them?
Well
Well
differentiated.
differentiated.
Sorry?
Well differentiated.
Well differentiated. So the only way to differentiate them is on histology. Is it a well differentiated neuroendocrine tumor, or is it a poorly differentiated neuroendocrine carcinoma? This is the only way to differentiate. Okay? So what are the differences between NET grade 3 and NEC?
Ma'am, NET grade 3 having organoid pattern.
Who is answering this now? Arushi? Okay,
Yes.
Arushi, continue.
Ma'am, NET grade 3 having organoid pattern, no necrosis, ma'am, whereas NEC having a solid sheet, present in solid sheets, no organoid pattern, and ma'am having necrosis.
Yeah. Any other features? Anyone else wants to contribute or add to this?
Nucleoli
Manish,
also
that is
is
sharing.
prominent.
Manish,
Nucleoli is
bolo.
prominent. Nucleoli is more
Yeah,
prominent
correct.
in
Correct.
uh,
NEC.
neuro-
Anything else?
and it is inconspicuous in grade 3 NET, and vesicular nuclei is present in carcinoma
Anything else?
and
Okay, so this you have already told me about the differences in the nuclei and the nuclear chromatin, right? And the pattern. Okay, now the other important things to remember is between small cell and large cell. Small cell will show, as most small cell tumors show, a bit of nuclear molding and streaming, right? And large cells, of course, are large cells with prominent nucleoli. Now, synapto and chroma are usually positive in a well differentiated tumor, but they can be variable in a poorly differentiated. So, if you have histologically realized that it is a poorly differentiated tumor, remember that synapto and chroma can be uh, variable. Okay. And of course, the response to therapy is different, which is how the first time It was proposed by an article by Dr. Bastook and their group, a lot of other, people working on this, that poorly differentiated, what they were earlier calling net 3, grade 3, had actually two components. One was poorly differentiated, one was well differentiated, and they differed in their response to the type of treatment. And therefore, it was important to now segregate them. Okay, at the end of the day, whatever we are trying to do is give the clinician some value, not just say, hey, it is NET 1, 2, 3, doesn't make a difference to him. Then there's no point. Now, because it makes a difference to the therapy, therefore, we must be able to give them the correct information, right? Now, what is grade progression? Garima? Sherin? What is grade progression? Okay, so if you are not telling, then I may as well, in the essence of time. Grade progression is when the tumor, in the same tumor or in its subsequent another tumor develops in the same patient, it is having a different grade. Okay, so for example, first time it was grade 1, another tumor at the same time, synchronous or metachronous, is grade 2 or grade 3. That is called grade progression. It occurs in neuroendocrine tumors, not in neuroendocrine carcinomas. It's not described in the carcinomas. Okay. They are already small cell or large cell and they maintain that phenotype. Now, the other important thing in these are the genomic differences. So here you can see I have put a picture of 4 immunohistochemistry, P53, RB1 loss, SMAD4 loss, and ATRX loss. Do you want to tell me which ones are in neuroendocrine carcinoma and which are in neuroendocrine tumor?
It's neuroendocrine carcinoma.
Okay.
And
P53 in carcinoma, RB1 loss,
I'm also in carcinoma.
also in
SMAD4 loss,
I'm in tumor,
tumor.
neuroendocrine.
no, also in carcinoma, and ATRX loss
tumor.
in tumor.
Tumor.
Okay, so the ones in red are the ones that are applicable to neuroendocrine carcinoma, and ATRX loss can be seen in neuroendocrine tumors. Okay. Now, you know of synaptochromo and CD56, which is not a very specific marker, but if you do not get anything else, then you can use CD56. What is INSEM 1 and what is the importance of keratin? I've already listed that out here in a way. So, does anyone know what is INSEM 1? INSM1?
Yeah. It states that nuclear positivity case.
And it's a marker for?
Neuroendocrine, it gives diffuse nuclear positivity.
Yeah, it's a marker for neuroendocrine tumors and it has a very high sensitivity and specificity. Okay. And what is the importance of keratin? So keratin, bolo.
Keratin will be negative in non-epithelial neuroendocrine.
Yeah. So it is negative. What are non-epithelial? I've written that also. Pheochromo and paragangliomas. These are non-epithelial neuroendocrine neoplasms in a way. So if keratin is negative, you often get it positive, and sometimes it can be a dot-like positivity, but that is also positive. So if you get a positivity, it is likely to be a neuroendocrine tumor. But if you do not get any positivity, make sure you have ruled out these other non-epithelial neuroendocrine neoplasms, especially depending on the location. Now, INSEM1 is an insulinoma associated protein, which has a very high sensitivity and specificity. Now, Sherry, want to describe this?
Yes, ma'am. At this power, the section shows diffuse proliferation of tumor cells like invading into the submucosa.
Is the entire picture slide showing the same morphology?
No, ma'am. In the mucosal surface, it is arranged in nest and it is diffusely in sheets beneath that.
Yeah. So what is happening here and what is happening here?
Ma'am, this is like a great progression in the upper, in the mucosal part. It is still showing organoid or in nest, and
Okay.
beneath that, it
Okay.
is
So
becoming
now
solid sheets.
this is cytokeratin
Yes,
and this is synaptophysin. Now, do you want to say what it is?
ma'am. This is a mixed neuroendocrine adenocarcinoma.
Mixed,
Neuroendocrine,
neuroendocrine, non-neuroendocrine.
non-neuroendocrine.
Correct. Where the non one is an adenocarcinoma. And the neuroendocrine component is a small cell neuroendocrine carcinoma. And ideally, you give the percentage of each, which must be more than 30%. Right?
Yes, ma'am.
Now, Manish, you take up case 3. We'll go through case 3 and 4 really fast, okay? So this is a 54-year-old female with jaundice. Endoscopy shows a small ampullary tumor. This
This section shows a tumor composed of
These were the 4 slides shared with you, right? Do you want to tell your findings?
in first section. Uh, in first section, it shows a tumor composed of a triphasic tumor composed of spindle cells, the epithelial cell arranged in nest, and ganglion cells.
Okay, very good. So you can see that in this as well,
It is
right?
very,
Here,
the
where are the ganglion cells in this one? Just tell me the quadrant.
ganglion cells are present in 3 o'clock.
Okay,
And
correct.
5 o'clock
Okay, and also a few in the center here.
central.
And what are these?
These are the epithelial component,
The normal or abnormal?
abnormal.
These are normal, okay? And these are the ganglion cells. So what is your diagnosis?
It might be a case of gangliocytic paraganglioma.
Excellent. So this is a gangliocytic paraganglioma. And what test would you do to confirm?
It will be positive for neuroendocrine. For each component, we can test for epithelial spindle cells and the ganglion cells. We can do ISC.
So what
Mainly,
3 markers would you do if you were given a choice?
neuroendocrine marker we can do S100, and mainly the gangliocytic paraganglioma. It arises from the neuroectodermal cells of primitive pancreas. So pancreatic polypeptide also it may be positive.
Okay, but first to just make a diagnosis, better to use 3 broad spectrum markers like synaptophysin, S100, and maybe NFP. Right? So these are the other slides from the same picture where you can see the loose neurofibroma component, the nesting pattern. Here again, the nesting pattern, the neurofibroma component with the ganglion cells here. Here, the one area I've highlighted, but it is actually all over. And these are the normal crypt glands, right? The ones with goblet cells. These are the normal glands. This is a high power of the neuroendocrine tumor component. The ganglion cells in the neurofibroma component. again a high power. And this is synaptophysin, which will also stain the nerve fibers to some extent and the ganglion cell, right? Promogranulin is a little more specific. Calretinin stains the ganglion cells. S100 and NFP, right? So this is a gangliocytic paraganglioma, very right. Now, Sherin, you take the last case.
This was a 35-year-old male, a known alcoholic who was being evaluated for chronic liver disease on routine upper GI endoscopy for esophageal varices, showed an incidental small yellowish white nodular lesion measuring 1.2 centimeter in diameter in the lower esophagus.
Yeah. And so the slides that you were given were this.
Yes. On this
And
power,
this.
we can see
Yeah.
a stratified. On this power, we can see a stratified squamous epithelium line tissue bit, indicating that most probably this is from a esophagus. And the subepithelium is showing tumor cells in diffuse sheets. The tumor cells are large, polygonal, with abundant granular eosinophilic cytoplasm and a small round nucleus.
This is the PS stain of the same. Okay.
It
So,
shows.
what is your diagnosis?
I thought of this to be a granular cell tumor.
Correct. And what special stain would you use to confirm?
We did pass to highlight the intracytoplasmic.
Correct. And any immunohistochemistry you'd like to do?
Yes, ma'am. We can do S100 for highlighting this tumor. Inhibin A we can do.
Okay, very good. So this was the tumor grossly, a very tiny tumor. And this is S100 showing positivity. So these granular cell tumors are usually small tumors, right? And malignancy is very rare in them. And the other tumors that are usually larger but can be small like this, you must look out for are leiomyomas, fibrovascular polyps, cyst, and leiomyosarcoma. Okay. So the immunohistochemistry, S100 is usually the most common one done, although a large number of markers can come positive. But the most simple, straightforward one that is usually used is S100, if at all it is required. And what would be the features favoring malignancy?
It would be necrosis, large nucleoli, spindling of the cells, like it has a grading system.
And size of the tumor?
Size of the
Size also. If it's a large tumor, then it is favoring malignancy. So a tumor more than 5 centimeter, and then other features which are typical features of malignancy. Increased cellularity, necrosis, spindling, large nucleoli, mitotic activity, and nuclear pleomorphism. Okay. So I think that's all for my part of the slide seminar. If there are any questions, you can ask me. And otherwise, I hand it over to the moderators to take it further.
Thank you, ma'am.
Should I stop
You
sharing my
can please
screen?
stop sharing your screen, ma'am.
Yeah. Okay.
Kedar sir, over to you, sir.
Okay, Dr. Ram, you want to take questions now or later?
Right now, there is only one question which has appeared in the chat box. Madam, is there any size for the microadenoma?
No, there isn't any size for the microadenoma, but usually the microadenomas are then called that if they are not really visible. So if they are not visible and if they are not on the surface like usual adenomas, it is just a synonym to the aberrant crypt foci.
Thank you, ma'am. Sir, I think you can start, sir.
Okay. Thank you all, and thank you, Dr. Ramaswamy, Dr. Burgess, and Dr. Gujral. Actually, Dr. Pooja has made my life easier because whatever the cases I'm going to describe, I think she has given a lot of several important tips in case number 2 and case number 3 about the cases that I'm going to describe. So I ask Dr. Arushi, Dr. Garima, Dr. Manish, whoever wants to take case number 1. We have 4 cases. Who wants to go first?
So it is my case number 1. Mine. Garima, sir.
Okay, Dr. Garima. Right. So before we go on to the slide, I think I'll just give you, because we have a very short history. We have a 58-year-old male, small intestinal tumor. And I think my personal approach will be actually, I want to gather maximum information as I can before I start seeing the slides. I know that there are excellent or fantastic pathologists who actually have a different approach, who pick up the slide first. They will say that don't tell me any history, and they will try to look at the slide, note the findings, and come to a conclusion, and then say, okay, this is that. That's a different approach. No approach is right or wrong in my mind, but I think what I will approach a case is that I will try to gather maximum information before I see the slides. And we are fortunate in Tata Hospital to have electronic medical records so that we can actually have clinical findings, complaints, radiology findings, tumor marker levels, and so on and so forth. And then we have a biopsy, or say resection specimen, and then we try to interpret the results. So my approach is that if I get the information, I try to come to some plausible diagnosis based on our knowledge of, say, general pathology, systemic pathology. What could be the possible diagnosis, and then I try to approach the slides. So, Dr. Garima, so because the history is 58-year-old male, let's start. Are the tumors of small intestine common? What are the benign and malignant tumors that occur in small intestine? And are there any special circumstances where they occur more frequently?
So, sir, small intestinal tumors are not very common.
Not very common.
Epidemiology says that it is 1.3 to 2.3 per cases per 1 lakh population.
Correct. I agree with
It
you.
is less than 3% overall GI cancers it contributes.
Correct. So you've done very well. But I mean, if suppose we have somebody says there is a small intestinal tumor on histology, which comes to us for a resection specimen, we have grossed it and we have prepared a slide. What could be the benign or malignant tumors that occur in small intestine?
So in benign, where there can be adenomatous polyp with low-grade dysplasia, high-grade dysplasia, intestinal adenoma with low-grade dysplasia, high-grade dysplasia, then serrated polyps with low-grade dysplasia, high-grade dysplasia, then malignant tumors, it can be adenocarcinoma. There are 6 variants of adenocarcinoma: mucinous signet ring, intestinal type, pancreatobiliary, tubular. Then sir, neuroendocrine tumors, it can be, and then neuroendocrine carcinomas, small cell and large cell type.
Okay, I think you really studied well. One correction is that, say, if you are dealing with an adenoma, especially in the proximal part of the small intestine, there may not be any resection specimen with us. Well, there may be an exceptions, and anything which is a low-grade dysplasia again will not come to us as a resection, because one has to be very sure in order to proceed with a very definitive large surgery. Anyway. So you're right in answering that. And are there any special circumstances where carcinomas occur in small intestine more frequently than the others?
Might be in some chronic inflammatory conditions like Crohn's disease, celiac disease, sir.
Yes, yes, you're right. So I think, so as we have the questions, are tumors of small intestine common? No. What are the benign and malignant tumors that occur in small intestines? Usually, if we divide into epithelial, mesenchymal, or lymphoid tissues, or lymphoid neoplasms, adenomas, NETs are actually, and Pooja Madam described it actually extensively with a lot of finer details. Carcinomas, other common examples would be gastrointestinal stromal tumors. It could be smooth muscle tumors, it could be nerve sheath tumors, it could be clear cell sarcomas, follicular dendritic cell tumors, and lymphomas. Lymphomas could be actually diffuse large B-cell lymphoma, or it could be maltomas, could be T-cell lymphomas. Don't forget metastasis to small intestine. Don't forget endometriosis, although which is a non-cancerous condition, but endometriosis can result in actually resection of the specimen. And rarely we can have a resection as a part of the extension from the large bowel tumor. So we are talking about specimen received at the grossing table at histopathology lab. And are there any medical conditions where carcinoma occur more frequently? Yes, FAP, familial adenomatous polyposis, and Crohn's disease. Yes, that's correct. So let's go on to the slides. How do you describe these slides?
So section shows tumor cells arranged in glands as well as cribriform pattern.
Yes.
Lumen is filled with secretions and separated by desmoplastic stroma, sir.
Yes.
And these cells shows moderate nuclear pleomorphism, high NC ratio, vesicular chromatin,
Yeah.
and conspicuous nucleoli in some.
Yeah. So obviously, I haven't shown you the gross picture because I don't have a gross picture, but this was kind of causing a stricturous lesion in the small bowel, mainly actually ileum. And we did see when we took sections, we did see a malignant tumor mainly formed of glands, some cribriform areas, and pleomorphic cells with a lot of desmoplastic reaction in between. So again, on the higher power, we did have there is a moderate amount of nuclear pleomorphism. Again, cribriform areas, desmoplastic areas. So what is the diagnosis?
Sir, I will be going, either it can be METS or it can be adenocarcinoma of the small intestine.
Okay, why METS?
Sir, origin, I'm not able to appreciate the origin.
Okay, okay. So what about this particular slide? This particular slide
Sir,
shows
here
you.
I can see the tumor cells reaching up to the serosal fat adjacent to a medium-sized muscular artery.
Yes, this is subserosal fat. There is a small, let me just, okay. Okay, so we have tumor cells infiltrating the fat. This is a medium-sized artery, and we have small nerve twigs, but the tumor cells are not seen around the twigs, but tells us that we should examine more section from this area to look for lymphatic emboli as well as perineural infiltration. So this means this at least PT3 tumor. So essentially, what we are looking for, actually, what we want to make is that the final diagnosis we have to make TNM stage. So this is an adenocarcinoma, moderately differentiated PT3. That's how we have reached, right?
Yes, sir.
Okay. So again, another section which shows tumor cells, and they are, I think, by contiguity, they are infiltrating a lymph node, which is in the mesenteric fat. They're not only invading the subcapsular area, but also slightly deeper. So by showing you 2-3 slides, I've given you TNM stage. What is a TNM stage?
Stage, sir, 2, 3. Stage 2, sir.
Why
Might
stage
be
2B? The previous slide, we actually saw something beyond the
T3.
muscularis mucosa, muscularis
T,
propria. So T3,
T3 and 1.
T3 and 1, that's right. And there's last slide, which shows actually something else also. So what is this?
Serosal membrane, sir. Tumor is lining the serosal membrane.
Yes, that's right. So essentially, what experts tell us that is that even in right hemicolectomy or colectomies, when we have actually serosal reflections and when it dips down, that's the area we should concentrate upon to look for the serosal involvement or PT4A area. So this is where we are looking at kind of a serosal or mesothelial lining infiltration or dipping down, and we have tumor cells, I think, reaching quite well into that crevices or depth. So this actually is an example of PT4A. So I'm trying to give you small tips as to where do we focus on. If required, we should do serial deep cuts on such area. And if we see tumor cells reaching onto the serosal surface or any desmoplastic reaction at this area, this becomes PT4A rather than PT3. So this is an adenocarcinoma. So this is not a very difficult diagnosis histology wise, PT4A N1 or at least N1. If we go on to the, just a minute, let me just, okay. So couple of slides as far as the theory is concerned. Small bowel adenocarcinomas are rare. despite the fact that the small intestine contains 75% of the length of the alimentary tract with 90% of surface mucosal area. They constitute approximately only 1 to 5% of all GI malignancies. Obviously, large bowel tumors are much more common. The tumors that arise in small intestine are adenocarcinomas, which is 24 to 44%, followed closely by well-differentiated neuroendocrine tumors, and Dr. Pooja showed us some nice examples of that, and followed by gastrointestinal stromal tumors, which is 7 to 9%, and then followed by lymphomas. Small intestinal adenocarcinomas are uncommon malignancies. In this location, the commoner sites are duodenum, which is predominantly or 52%, usually periampullary tumors. Then comes jejunum, which is 18-19%, and then ileum, which is 17 to 18%. Not otherwise specified at 12%. So this particular thing was clinically and radiologically a primary tumor. So there's nothing, no catch in this particular location. There was no known primary, and this particular thing was indeed a primary tumor which got resected. Can you tell us about the immunohistochemistry features of a small intestinal adenocarcinoma? Dr.
So
Garima?
yes, sir, pan-CK we will apply, then we can do cytokeratin 7 and 20. It will be positive for CK20.
Yes. So it will usually, it expresses both cytokeratin 7 and 20. That's the thing. If we are looking at metastasis from somewhere else, say from colon, it will be more CK20 positive, 7 negative. But I mean, if you can't distinguish any other tumor primary in the pancreas or gallbladder or stomach coming to small intestine from immunohistochemistry alone, this will not be possible. So this was a first case, relatively straightforward, but of course a rare tumor nonetheless at this location. Our job is to fulfilling the minimum data sets required, and lymph node dissection is important. Dr. Garima, we know that in the rectum we need at least 12 lymph nodes for colectomy specimen. Do you know how many nodes do we require for small intestinal specimen? I mean, I've given you answer here.
12 only, sir.
No, read the lines, please. So it said that, and this is quoted from the AJCC 8th Atlas, is that optimum staging will be achieved by at least 5 nodes in a non-ampullary duodenal adenocarcinomas and at least 9 nodes for small intestinal adenocarcinomas. This is from AJCC 8th manual. So the most crucial point is to give you TNM stage. TNM stage is similar to carcinoma stomach here. N1 is 1 to 2 nodes, whereas N2 is more than 2 nodes. So we actually, in 2 to 3 slides, we got up to PT4AN1, and that's what I think that's enough for us to actually complete the stage 1, complete the case 1. I've added a couple of examples as rare examples in this location. Dr. Pooja did show us about the neuroendocrine tumor, and she told us about the very many finer points. So this is one such example of well-differentiated neuroendocrine tumor, which also resulted in the resection of the small intestine. We can see this nested pattern occupying entire submucosa as well as muscularis propria of the small intestine. They are synaptophysin positive, chromogranin positive, and MIB1 index is actually very low, maybe about 1%. This is actually a very rare example which we saw. This came as an outside case report. And Dr. Garima, can you describe what is this? This is actually this is a major surgery. It came to us from outside as a pylorus preserving pancreatic duodenectomy for a large duodenal tumor, and this was about 5 centimeter in size.
I can see, sir, Brunner's gland, lot of.
Yes. This actually was extremely uncommon. We actually see a lot of Brunner's glands, and so much so that I mean, there's a debate actually what is hamartoma, what is hyperplasia, and what is adenoma. But this particular tumor was large in size. It was so much so that some of the literature described it as a giant Brunner adenoma, and this constituted normal-looking Brunner's gland, but they occupied not only the submucosa, but they occupied part of the muscularis propria, giving rise to a tumor in the wall of the duodenum. So, whereas the Brunner's glands usually situated
In the submucosa, sir.
mucosa or submucosa, that's right. So this was just a very rare example, and we thought, I think we can share it with you, which resulted in a supramajor surgery. Usually this is not the case. Brunner gland adenoma is usually diagnosed on the biopsy or hyperplasia or hematoma, and then one can follow the case as long as we are sure of the diagnosis. Okay, this is an example of a normal small intestinal mucosa. And what are these things, Dr. Garima? These are called as
Goblet cells are increased, sir, somewhat.
crypts of Lieberkühn. Crypts of Lieberkühn are basically nothing but actually normal constituents of the small intestine. And normal small intestinal mucosa is composed of relatively, I mean, usually 4 types of cells: enterocytes, goblet cells, Paneth cells, and endocrine cells. So, which are the Paneth cells? And how do you distinguish Paneth cells from the endocrine cell? This is a section of normal small intestinal crypt. Just because we are in this location, I thought I'll share with you the normal histology, because it has some relevance to what Dr. Pooja described and has some relevance to what we are describing later on. Okay,
Sir,
the Paneth cells. Paneth cells. How do you recognize Paneth cells? What is the difference between
Sir, in
Paneth cells?
in Paneth cells, there will be supranuclear granules will be present, while in
Correct.
neuroendocrine cells there will
That's
be
very right.
subnuclear.
That's very right. So Paneth cells are distinct. They show supranuclear granules, and these are the cells they usually secrete growth factors, which are required for the normal small intestinal mucosal development, whereas neuroendocrine cells are the infranuclear cells, and that's all that there to this slide. Going on to the next case, who's taking the next case, please?
Sir, I am.
Anyone?
Sir, I am Dr. Arushi will take next
Dr.
case.
Arushi, okay, this is relatively easy to diagnose, but indeed a rare case. Can you describe the case?
Sir, 55-year male.
Yes, 55-year-old male rectal tumor.
Sir, in first microphotograph, we can see there is normal rectal mucosa. A lesion is arising. It seems to be arising from some mucosa and involving the deeper layer.
Yes, that's right. So top left, we can see mucosal area on the right side, and there's a tumor on. This is relatively a solid tumor. Top right, we can see slightly high power. We can see a tumor here, and the bottom cells. How do you describe this tumor?
Sir, here we can see the tumor cell infiltrate up to the mucosa.
No, the architecture. I mean, how do you describe the tumor?
So, nested pattern.
Yes,
Being
that's right.
separated
So
by
slightly on a higher power. How do you describe the tumor?
So, in higher power, the tumor cell arranged in organoid or nested pattern, being
Yes.
separated by fibrous septa.
Yes.
So, these are uniform round cells
Yes.
having
So
moderate amount of eosinophilic cytoplasm.
that's absolutely right. Anything else? Slightly higher power. What do we see? We see relatively uniform nuclei, nested pattern, fibrous septae. Anything else? Is there any necrosis?
So here we can appreciate mitosis.
Mitosis, okay, it's not very high power, but mitosis actually are not very frequent in this particular tumor. Okay, I'll give you a higher power again here. Mitosis, to be honest, are actually not conspicuous in this particular tumor.
So here we can appreciate the chromatin of the cells, which is salt and paper.
Yes. So what do you think are the differential diagnosis here?
So it might be well differentiated neuroendocrine tumor.
Right. Anything else? Okay, so I think you are right in considering that. So we have top left synaptophysin positive. From the internal control, I have given you part of the colonic mucosal gland, which is negative here. Chromogranin positive. Again, I've given you in the inside and internal control, the gland is negative. What about this? Can you
Sir,
describe the further immunohistochemistry? I've given you answer in this slide.
sir, AE1 or AE3 is negative, which shows it is not paraganglioma.
It shows which is not.
Paraganglioma.
No, I think
No.
it shows it is not an epithelial neuroendocrine type of tumor.
Yes, sir.
Okay, the
Sir,
normal colonic glands are brilliantly positive on the right top area.
sir,
What about
MIB.
mid-one? Mid-one
Sir,
is
it is proliferative index,
yes,
or also called as Ki67 index.
yes, that's
Sir,
right.
we can do grading based on the counting of 500 cells.
Yes.
Sir,
So although Madam said and told us that eyeballing is not recommended, but maybe how much would you put it as a percentage here?
so, sir, 8%.
2, 3, 4, 5%. Okay.
No,
What about GATA3? What is the significance of GATA3 and what are these S100 protein cells showing?
sir, GATA3 is negative.
GATA3 actually is positive. It is not very brilliantly positive, but it is positive. GATA3 is a nuclear marker, and S100 protein
Sir, it is positive,
positive.
which shows neuroendocrine
So
neural
what
origin.
what is the diagnosis that we are looking at?
Paraganglioma.
Yes.
S100 is positive in sustentacular cells.
Yes, S100. So this is a tumor. Now you can go back to the histology and perhaps appreciate what I was trying to show you. This is indeed a Zell-Ballen pattern. These are tumors which are non-epithelial neuroendocrine tumors. They form pockets or glands, and usually the appearance is same, whatever is the location. Okay, so they occur in carotid body, they occur in larynx, they occur in stomach, they occur in any other area, but usually the or non-adrenal locations, retroperitoneal locations, but usually the appearance is the same. Necrosis is not seen. Mitotic activity is sparse, and the diagnosis is based on the combination of morphology as well as immunohistochemistry. Immunohistochemistry, in that it is a synaptophysin chromogranin positive, MIB1 usually low, GATA3 positive, S100 positive in sustentacular cells, and also sometimes, but we must remember that S100 actually is one of the secondary neuroendocrine marker. So S100 protein can be positive in tumor cells in addition to sustentacular cells, and even A3 is actually negative in this cell. So this is indeed a paraganglioma. Uh, Paragangliomas are rare, but have you seen it in rectum? The finding and diagnosis histologically is not difficult here, but the location is actually rare here. That's why I have shown it here. Paragangliomas are rare but well described in non-epithelial tumors, typically developed at the extra-adrenal sites, along with sympathetic and or parasympathetic chain. They are usually seen in head and neck region, what we describe as carotid body tumors, or urogenital tract actually is one of the commonest site. Few are described in stomach, but in GI tract, they are extremely rare, and they are especially rare in rectum. Differential diagnosis could be epithelioid gastrointestinal stromal tumor. So this is one such example of paraganglioma occurring in rectum. This resulted in actually anterior resection of the rectum, and this was indeed a histological novelty and rarity at this site. But nonetheless, histological appearance is identifiable from our knowledge of urogenital tract tumor or a carotid body tumor. So these are usually mitotically sparse, and there are criteria described. The only criteria described as a definite criteria for malignancy is that if we see actually malignant focus, malignant metastasis, then we call it malignant paraganglioma. Otherwise, malignant paraganglioma is actually a difficult diagnosis to make. But if you have necrosis, if you have high mitotic activity, if you have high cytological atypia, one can think of or suggest the malignant behavior could be considered. MIB1 can be high, but usually they all are termed as paraganglioma, and if we have a definite metastasis, then only we call it malignant paraganglioma. That finishes our case number 2. It was not a difficult histology, but a rare location. That's why I thought I'll keep it here. And Dr. Pooja's cases are really helping me, and her discussion is really helping me to come to the diagnosis, because she gave us some very fine nuances about Ki67 reading. Even if there is any faint staining, we should have Ki67 reading. How much is the mitotic activity, and so on and so forth. Paraganglioma, by definition, are epithelial markers negative, whereas NET or carcinomas are epithelial markers positive. Although in carcinomas, epithelial markers can be actually focal or patchy. So who's taking case number 3?
This is my case.
Okay, Manish. Okay, Manish, we have
female, multiple liver lesions. Yes,
right, multiple liver lesions, metastasis, and liver biopsy. So I'll give you some questions. What are the multiple liver lesions? Why would you have multiple liver lesions? 38-year-old female, what would be the multiple liver lesions could be due
to? Either in female, not in female, but in adults, mainly in chronic alcoholics, there may be multiple fatty nodules may be present. There may be metastasis, or there may be multiple infection causing
multiple fatty nodules. Okay, so let's discuss. Okay, so inflammatory, yes. So do you mean multiple liver lesions or multiple liver abscesses?
Multiple liver abscesses may be present.
Possible. So what do you do? So what do you look for clinical history then?
We will look for signs of any infection, inflammatory condition. Their acute phase reactants will be raised, and fever, yes, or many clinical features
such as. So we have not yet seen the slides. I'm only looking at 38-year-old female multiple liver lesions. That's why I'm thinking, are these abscesses? What do I look for?
Maybe abdominal pain may be associated in case of gastroenteritis.
Okay, so
pain also.
If they are abscesses, I look for acute phase reactants such as, okay, so total count, is a total count high? Is the C-reactive protein high? You're right. Is there a fever? Is there a patient is toxic? Something like that, so on and so forth. Okay. Now, if these lesions are indeed neoplastic, what could be the differential diagnosis in history? What should we look for?
If patient is a non-alcoholic, or there is a history of hepatitis, then we can suspect hepatocellular carcinoma in chronic cases.
Okay, there is no such history in this case. There is no fatty liver. Sorry, go on. I can't hear you properly, Manish. We are trying to discuss the possibilities, and I'm trying to give you the clinical scenario. There is no history of alcoholic liver disease. There is no history of chronic liver disease.
There might be history of smoking. In case of lung carcinoma, there may be metastasis to liver, or in case of breast cancers.
Smoking, you mean lung primary and liver secondary?
Secondaries. I'm talking about the secondaries, metastasis.
Smoking.
There might be a possibility then.
No, that sounds a little far-fetched. Smoking giving rise to, no, smoking should be of a substantial duration to give rise to lung carcinomas. It could be squamous carcinomas or small cell carcinomas. Usually, adenocarcinomas may not be associated with smoking. And then, in order to have liver mets, she seems young to me. Okay, anyway, but suppose we look at a neoplastic pathology. Can it be multifocal HCC, hepatocellular carcinoma?
Multifocal, not sure, sir.
No, okay. Can it be multifocal cholangiocarcinoma? I think that is a possibility. If I tell you this is the total count is fine, patient has on radiology multiple liver nodules. Could it be metastasis? That's the clinical query raised. Could it be metastasis? So in this case, there was no primary was known, no stomach, no gallbladder, no pancreas, no primary was known. So we are left with actually and not an inflammatory scenario. What could be the second? What could be the neoplastic scenario? Could it be multifocal SCC? Could it be multifocal cholangiocarcinoma? If I tell you, look into the history, what will you look for? Okay, we'll go on to the next slide and maybe we can discuss this. So inflammatory conditions, we look for abscesses, infections, patient may be immunocompromised, so we need to know that, or go to the history, CBC, C-reactive protein. In neoplastic, if we are thinking of metastatic carcinoma or multifocal cholangiocarcinoma or HCC, these two are probably the main things. So we are looking for chronic liver disease history, viral status, B virus, C virus. We are looking for LFT. In LFT, we are looking for examples of or signs and of suggestion of chronic liver disease. We are looking for albumin globulin reversal. We are looking for radiology. Radiology, ultrasound or CT scan sometimes can tell us nodularity, in the surface nodularity. Arterial phase enhancement is one of the features described in contrast CT scan in HCCs. Portal vein thrombosis is one of the signs and symptoms, one of the signs which is associated with HCCs. And of course, alpha fetoprotein is raised in HCCs. Manish, in how many percentage of hepatocellular carcinoma alpha fetoprotein is raised? Is it raised in all the HCC cases?
So it is raised.
Sorry, I can't hear you. Yeah.
Yes, it is raised in around 40%. 40,
No, I think your voice is breaking. I think
40 to
the answer.
50%
Alpha fetoprotein,
Sir,
serum alpha fetoprotein is raised usually in
40%,
30, 25 to 30% of the cases.
Sorry.
Sorry, your voice is breaking, but I'll give the answer. Alpha fetoprotein serum is raised in about 25 to 30% of cases. And usually, if the values are more than 1,000, then we are almost sure that this is indeed a hepatocellular carcinoma. Any lower values will not able to give us a strong diagnosis, but obviously we'll have to resort to biopsy to go to the diagnosis. Another point is that multiple lesions could be neuroendocrine tumor, and the primary can be actually very small. It could be in GIT, stomach, jejunum, or the pancreas, or any other rare cause. So let's go on to the histology. Manish, can you describe the slide? I've just given you the slide so as to show that this is actually indeed was a liver biopsy. Manish, can you hear me? I'm sorry, Manish, I can't hear Manish. Sharing, do you want to take that?
Yes, sir.
Hello.
Sorry, okay, Manish, go on.
This section shows multiple scattered signating cells with cytoplasmic mucin content and eccentrically placed nucleus.
Okay.
And these cells appear loosely cohesive. There is no proper gland formation here.
Okay. So what?
So possibly we can think of signet cell adenocarcinoma,
Okay. You're right in thinking
and we
about
can
that.
keep a differential cells. Some of the cells shows like epithelial cells like morphology.
Yes.
Can we keep a differential of endothelioma, hemangioendothelioma, epithelial hemangioendothelioma?
Yes. So I think you're right in considering these diagnoses, but what will be the clinical scenario, Manish? Metastatic signet ring carcinoma and epithelial hemangioendothelioma. What will be the patient be performance status wise?
In if it would be a signet cell carcinoma, a signet ring adenocarcinoma, then patient prognosis would be bad because there is some primary tumor somewhere in the. We have to look for that.
Yes.
We can do
Performance status, meaning patient general condition.
It has a poor prognosis. So
I mean, no. What I mean to ask
there
is
will
that
be
what will be the patient's activities, routine activities? What I'm trying to derive at, yeah, what I'm
there
trying to derive it
will
is that
be weight loss of moderate.
if this is a metastatic signet cell adenocarcinoma in the liver, usually there will be a primary known, or primary will be known on the radiology or CT scan. May it be stomach, may it be colon, and then it's a high stage disease. It could also may will result in ascitic fluid. The patient general condition will be bad. Patient will be losing weight. Really loss of appetite, and so on and so forth. So two things I want to actually derive at. You considered right differential diagnosis, but if patient has multiple liver nodules and patient general condition is actually fair to actually all right, we should think of two conditions. One is actually multifocal neuroendocrine tumor in the liver, and hepatic hemangioendothelioma. These are the ones which are usually low-grade malignancy, and they will see patients relatively constitution-wise well preserved, whereas high-grade adenocarcinoma, poorly differentiated adenocarcinoma patient will be in a poor general condition. That's what I was trying to look at from the history before we pick up the slides. So we have a biopsy here. We have a liver cells, and we have actually infiltration by neoplastic cells, which look to be actually rather stromal reaction here, fibrostromal reaction. We also have small cells which have actually lumina or cytoplasmic lumina. They seem to be interspersed in between the liver cells. And if you go on the high power, many of them show actually signet ring appearance, or maybe what are described as blister-like cells or blister-shaped cells. Some of them have some kind of a pinkish material in between this cell. So this lumina. So we are looking at, and this is a higher power, and again they look to me. Other thing I was looking for actually is for a carcinoma, they will show some amount of clustering or pocketing. These indeed are to be individually looking cells. They are atypical, but they are showing actually this cytoplasmic lumina. Some of them are showing some cytoplasmic, not RBCs, but some pinkish material. So I think indeed carcinoma or hemangioendothelioma are the differential diagnosis, and they are brilliantly cytokeratic CD34 positive, CD31 positive. This is TFE1, which is a nucleus stain. This is positive. So Manish, what is the diagnosis?
Sir, I have given a diagnosis of signet cell adenocarcinoma.
No, so you mentioned it.
CD30.
I've shown you the immunohistochemistry. Now, what is the diagnosis?
As a CD34, it can be a vascular tumor, maybe endothelioma.
Yes. Okay. So yeah. So this is a hepatic epithelioid hemangioendothelioma. This is an uncommon tumor. This is uncommon vascular tumor of low-grade malignancy. I was trying to stress upon the general features, clinical information, radiology, and so on and so forth, because just by looking at the radiology by multiple liver nodules, we may not be able to decipher histologically, because signature adenocarcinoma could be a differential diagnosis. But if you look at all the features, including clinical details, then actually this diagnosis can be thought of even on histopathology. So this is a tumor of low-grade malignancy of vascular nature, histologically characterized by the epithelioid morphology of tumor cells and abundant fibrotic stroma. This is in contrast to most other vascular neoplasms. This may develop in other organs such as lung, soft tissues, bone, and lymph nodes. Initially, it was thought as an unusual type of carcinoma or a sclerosing angiosarcoma or even a non-neoplastic fibrous lesion. But electron microscopy and ISC proved the endothelial origin. So first described in 1984 by Ishak et al. Called as hepatic epithelioid hemangioendothelioma, or HEHE. This is a very peculiar short form. Annual incidence is less than 0.1 per 100,000. Mean age is 42. Approximately 60% are women. And there are two characteristic findings: intracytoplasmic lumen with some containing RBCs and papillary polypoid growth inside blood vessels or sinusoids. We actually saw the first finding in these particular slides. One last slide about this patient, about this case, is that they are usually, they are positive for endothelial markers, CD31, CD34, ERG, or factor 8. Now, D240 can be aberrantly expressed in these cells. D240 is one of the endothelial markers of the lymphatics, which can be aberrantly expressed. Cytokeratin can be positive in these cells, so we have to watch for that. So if we are looking at cytokeratin positivity, we must look at some further a panel with CD31, CD34, in addition CEA, CK7, CK20, to actually look at, to exclude conclusively the diagnosis of signature cell adenocarcinoma. Diffuse nuclear staining for CAMTA1, which is or a TFE3, is indicates the presence of WWTR1 or CAMTA1 or WAP1 or TFE3 fusion gene respectively. We don't have that, but this is recently described immunomarkers. And DD could be cholangiocarcinoma or angiosarcoma. Cholangiocarcinoma, we will be helped by tumor markers, raised tumor markers such as serum CEA or CA19.9 if they are raised. Treatment is surgery, transplantation of liver, metronomic chemotherapy, or transarterial chemoembolization, depending on the extent of the disease. There is no particular defined therapy or because of the rarity of these cases. Our SR, Dr. Apurva Mundada, actually did write a short case report about these, brief communication of these, and which is published recently about hepatic hemangioendothelioma. And we saw about 23 cases, and most of them were actually biopsies. There were hardly any resections. But the chemotherapy they received were actually metronomic chemotherapy, and which was something to think about. Case number 4. Are you taking on case number 4?
Yes, sir. Yes.
I'm sorry, I think there is some background noise at my end, just outside my house. Is it disturbing you?
No, sir.
Then we'll quickly go on to case number 4. Yeah.
Yes, sir. She's a 39-year-old female
Yes.
with no known comorbidity and history of surgery of cystoduodenostomy on August 2014, and no further treatment details are available.
Yes, it's a short case we can describe. What we basically saw was a large multilobated separate cystic lesion in the head and uncinate process of the pancreas of 6 centimeter in size. Body and tail was atrophic. Can you describe the tumor, please?
Yes, sir. In this power we can see the part of normal pancreas along with large cystic spaces.
Yes.
I cannot describe the lining. There are no papillary excrescences, however, at this point.
Okay. So slightly a different area. Again, we have multicystic appearance.
Yes, yes.
Slightly higher power. Can you now see the slides?
Yes, sir. At this power, I can see the cystic spaces are lined by singly lined acinar cells.
Yes.
And even below the spaces also there is single lining of the acinar cells.
Yes. So they appear to be epithelial cells.
Epithelial
How do you
cells.
comment about dysplasia atypia? Or do you think it is malignant or benign?
Sir, since there is no stratification or nuclear atypia or papillary projections, this seems to be a benign tube.
Okay. So we have a multicystic tumor, appears to be lined by single layered of cells. Sometimes there is maybe, but I can't say that they are actually atypical cells. Cytoplasmic clearing actually is a feature. I don't see actually it is composed of mucin. Seems to be cytoplasmic clearing, and that's all, and so on and so forth. Again, some more areas, epithelium, no necrosis, no atypia, no mitotic activity, no atypical mitotic figures. So what is the diagnosis, possible diagnosis, Sharon?
Sir, I thought of acinar cystic transformation in pancreas or a serous cyst adenoma.
Yes. So if it is forming a nodule of 6 centimeter size, which required a limited or pancreatic resection, I think serous cystadenoma or
Cystadenoma.
multicystic cystadenoma pancreas is the right diagnosis. This is again a rare benign epithelial neoplasm of the pancreas, more common in body and tail. This particular thing happened to be in the head. If you see the earlier literature, in the sense, if you see the older edition of Fletcher oncopathology textbook, it says that it is predominantly young ladies, and female to male ratio was 9:1. But now we realize that it is obviously it is young ladies, but current literature does say that it can be seen in middle-aged ladies, middle-aged men. Occasionally, we recently saw one case in a 56-year-old man. Female to male ratio is approximately 4 to 5:1, and occasionally seen in middle-aged male. This particular case happened to be given to me by our colleague, consultant colleague, Dr. Subhash Yadav. Couple of slides are my photograph, but I'm thankful to Dr. Yadav for his contribution. And this is actually distinct clinico-pathological and radiological features, in that MRI and endoscopic ultrasound are actually quite diagnostic. And if they are diagnostic, if we can reach a diagnosis of cystadenoma of the pancreas, it can be followed up. Surgery is not required. Surgery will be required if it's a large lesion or is occurring or pressing on any important structure. Differential diagnosis would be mucinous cyst. This particular thing did not have mucinous epithelium, but if we have a mucinous epithelium, we have to be a little more careful or cautious, in that mucinous epithelium or mucinous adenomas, even though they are adenomas or not showing any features of malignancy, they are to be treated as potentially malignant, and those typically show ovarian type of stroma, which will be positive immunohistochemistry for ER and PR. So that will be the DD. Another DD would be degeneration in a carcinoma or cystic change in a spen or solid pseudopapillary epithelial neoplasm of the pancreas, which again is a tumor seen in young ladies. And surgery in this case is curative. So we'll see a couple of examples of related lesions, but not in the same organ. This happened to be actually a serous cystadenoma in the biliary tree, and it resulted in a huge cyst in the right side of the lobe of the pancreas, lobe of the liver, which necessitated a large surgery. So again, similar tumor. See, I'm showing this because this is indeed a rare example. This we saw about 10 years ago, and I don't think I've seen again. Probably our colleague has seen one such case. So biliary cystadenoma. These are rare tumors. You can see normal liver in the top bottom right. Again, a similar example of a biliary cystadenoma. This is an example of a young lady and a pancreatic tumor, and this showed a neoplasm again. No marks for guessing that. Looks like usually intermediate size cells, but some sort of cords or kind of a solid acini, good vascularity. Again, these are the probably tubules or pseudopapillae, relatively regular nuclei, some macrophages in between, but relatively regular nuclei. And again, DD here would be neuroendocrine tumor of the pancreas. This is in the pancreas, young lady, neuroendocrine tumor of the pancreas or solid papillary tumor of the pancreas, and this was beta-catenin nuclear positive. So this was indeed a case of a pseudopapillary tumor of the pancreas. So this was just as an example to show to share a case of one of the typical findings of SPEN of the pancreas. But our diagnosis of case number 1 is multicystic cystadenoma or serous cystadenoma of the pancreas. So I think, Dr. Ram, we have finished with the 4 cases, or any comments or questions we can take. Thank you.
Thank you, sir. I think you can stop sharing the screen, sir. Dr. Bonita, would you like to take up any queries?
Sir, we don't have much question, but one question regarding the node sampling of the small intestinal tumor. Sir,
Yes.
would you clarify on the node sampling of small intestinal tumors?
Node sampling meaning any all nodes are to be dissected. Any number actually is welcome. As many as is actually fine. What I quoted regarding the number of nodes, because usually we know the optimum or minimum number of nodes in colorectum is 12. Optimum number of nodes in stomach is usually 15, but usually desirable is 30. Such in that we don't have or we don't come across very commonly a kind of a magic figure in small intestine. That is one reason actually, because we don't see actually small intestinal resections for adenocarcinomas very commonly. But AJCC Atlas did say that for non-ampullary tumors, we must have at least 5 nodes, or for non-duodenal tumors in jejunum or small intestine, we must strive to have at least 9 nodes in order to give a proper TNM staging. And nodes are basically to be done with palpation. Indeed, we don't use actually any fat dissolving solution at all.
Thank you, sir.
If there are no more queries, Pooja ma'am, your comments, closing comments, and Kedar sir, your comments to end the sessions.
I'm happy to note that the students were well prepared. I think they looked at the cases